Okay, let's go to cancer diagnosis. We have no role in the uh, making the diagnosis, of course, as nurses. However, we need to be able to discuss these with the patient because let's say, who did I use last week as an example? Shanice, you're a mom, right? No? Oh, no? You're a mommy?
Yeah.
Okay. So how many kids do you have?
One.
Okay, doesn't matter how many. Let's say you got diagnosed with cancer today. So what will be your state of mind? And then the doctor proceeds with, he goes like this, okay, Shanice, you have stage 4 cancer. Our plan is to give you 3 treatments. We're going to do surgery, chemo, well, in the order of radiation first, then chemo next, and then we'll take the tumor out. Right? Any questions? How are you going to receive this on the same day that you got the diagnosis?
I'm gonna be upset.
Okay, so are you receptive to the teaching, to the plan? Okay, not so bad time, right? So she's in a grieving state. So what will be on your mind instead?
My child. That's
Just your child, nobody else in the picture?
no. Just my child.
What about me?
Based on me.
No?
What
Okay. All right. So exactly that point. So who will be around when the patient eventually gets to the acceptance stage of grieving, whenever that will be? Who will likely be there? Because we are there 24/7. Okay. So therefore, when they ask you a question, that indicates they're already at the acceptance, right? They're done with the anger and the bargaining stage. So now they're asking questions. Can you talk to me about the doctor mentioned this? So are you gonna say, hey, let me call the doctor? Are you gonna say that?
No.
Or are you gonna take this opportunity now to educate? All right, we have to do it now because we will miss it. All right. So we need to understand the diagnosis. So these are the purposes. So determine staging. So determine the present and extent. So that's staging of the cancer. This metastasis, identifying whether it's benign or malignant, and then what body systems are involved, including the lymphatic system. By lymphatic system, I mean the lymph nodes. And then for analysis, we need to see what type of cancer it is, meaning cytology testing. For staging, we'll skip the table 12-3. Again, we won't use this because this is not updated. We'll use the actual ACS website. Let's go to staging. We will use the universal TNM classification. Before that, table 12-4, I won't test you on tumor markers because, again, that's not our role. But I want you to be aware of what are the frequent tumor markers. Okay, before we get to the TNM. It's not mentioned here, but let's say it's on a test question. Common tumor markers are CA125, CA19-9, alpha fetoprotein or AFP. Okay, so these are tumor markers. What are tumor markers? These are enzymes that elevate when you have cancer. When you have cancer cells growing in your body, these are, let me put it this way. They're called tumor markers because now you're a born adult. Okay, you're already out of the uterus. These are absolutely normal in a fetus. What is a fetus? Or an embryo? You're still in the womb, right? Okay, so you're growing, correct? What did I mention last week on the cancer development? Do we have cancer characteristics?
Yes.
You know, when I said the brake pedal and the gas pedal, suppressor genes and oncogenes. Okay, so CA19-9, CA125, alpha fetoprotein, and the rest, they are normal in a growing embryo. Meaning if you get a blood sample and test the specimen, you will see CA125, CA99, AFP. These are absolutely normal in a growing embryo or fetus. Are they supposed to be normal in a person outside the womb now? Not anymore. Okay, because are you still rapidly developing like you were in the uterus? Not anymore. So these numbers, these enzymes should not be there anymore in high numbers. Yes, they're still in our body, but not in high numbers. Okay, very low levels. If they're high, that means it could indicate certain types of cancers. Let me give you an example. So let's go to a website and look at let's just do CA125. So what is CA125? What does it say? A test measuring for what type of cancer? Ovarian. What else? Fibroids, endometrial, peritoneal, and fallopian tube cancers. Right? The problem with this is it only present in these types of cancers? No. CA125, as is CA99, are also elevated in non-cancerous conditions. Let's say you have a liver problem, for instance, they can be elevated. So therefore, these tests, are they reliable as a prime diagnostic test for cancer? No, because again, are they exclusively seen in cancer? No, they are also present in non-cancerous conditions. However, can they help arrive at a diagnosis for cancer?
Yeah.
Yes, because can we send everybody to a CAT scan whenever we want? No, there has to be an indication. Why did you order a CAT scan or an MRI? You've been through this, right? I mean, you've had a a CAT scan, MRI order. Did you go directly, or did the provider have to contact your insurance company whether or not they'll approve it?
Yeah.
Okay, because that's how it works. These are tens of thousands of dollars worth. So they don't just do it because the doctor wants it. There has to be an indication why. Tell me, why are you ordering this? All right. So let's say the doctor orders CA125 and it comes back positive. It's high. And then you have the symptoms of the unusual bleeding, for instance, between your periods. Can they now justify a CAT scan? Yes, because now you have possible symptoms of cancer, okay? Endometrial or cervical cancer or ovarian cancer, because you have the symptoms and then the CA125 is elevated. So they will submit this as proof to the insurance company. Make sense? Yes, again, the point here is, are tumor markers used for diagnosing cancer? No, they can't. However, can they aid in the diagnosis? Yes. Okay. Are we clear?
Yeah.
Okay. Then you already know about mammo MRI. Again, these expensive radiology tests will only be approved if you have an approved or accepted indication. Of course, for mammogram and a CAT scan, these are again standard for which types of screening again? Screening for what type of cancer?
Breast cancer.
Breast, and what about the CAT scan? Of the chest, or lung or bronchial cancer. All right. The only indication there, of course, if you have a history of smoking. You're a smoker, and what age was that again for CAT scan? I don't exactly know the number, but very good if you memorized it. Any question about the diagnostics testing? All right, let's go to staging now. We'll only test TNM. So what is TNM? It's a universal staging classification for cancer. The acronym stands for tumor, lymph node, and metastasis. T, whether or not there is a primary tumor. N, the number of lymph nodes involved, or whether or not there are lymph nodes involved. M, whether or not there is spread or metastasis. And I'll give you an example of a scenario. When it says TX, that means this is not really good news. TX just means we have no idea. Doesn't say there's no tumor. Doesn't say there is a tumor. We don't know. They put TX. T0 is good. They say when the doctor writes T0, that means, is there a tumor? No. What about TX? We have no idea, right? Maybe there is, maybe not. I don't know. What about TIS? This means there is a tumor, but it's in situ. In situ meaning it's not likely to spread. It's located where it's originating. Meaning, let's say you have a breast tumor. It's just in the breast. Okay, and based on the radiology, it's not able to spread. Okay, so they'll put TIS, in situ. T1, 2, 3, 4, there's no T2000. Okay, it only goes from 1 to 4. 1 means small, T2, a little bigger, T3, no, good size, T4, really, really big. It's very subjective because there's no guideline as to if it's only, so many centimeters, it's T1. Okay, there's nothing like that. Plus, let's say the tumor is in the brain versus it's in the stomach. Will the size be the same? Let's say it's a T1 in the brain. Will it be the same T1 in the colon? No, because the skull is way smaller compared to the colon. Okay, so this is what I mean by there's some subjectivity here. So the doctor assigning the number bases it on the size based on the location. N would be the lymph nodes. Is there evidence of lymph node involvement? NX, just like TX, do we know?
No idea.
No idea. What about N0? This is good because there is no evidence of, we know there is no lymph node involvement. Okay, there's evidence to show no lymph nodes are involved. N1, 2, 3, this can go up to 6, 7, however many lymph nodes are involved because they count how many lymph nodes has the tumor spread to. Now, why is it significant if there is lymph node involvement? That means, okay, because now there's evidence that means the tumor has now entered the lymphatic system. So it spread into one lymph node, it can spread everywhere. And then metastasis, MX, what does that mean again? We don't know whether they're spread or not. What about M0? Okay, this is good because we know there's evidence showing there is no spread. It's only in one body system.
Can you explain again TIS?
Okay.
So in situ.
Okay, in situ. In situ means the cancer, the tumor is has some kind of membrane or capsule, meaning telling us that it's not likely to spread because if it's in a pouch or something, it cannot leave that pouch or that membrane. Okay, that's in situ. And then M would be the highest M would be about 7 because the most aggressive type of cancer is lung cancer and it can spread to up to 7 body systems. It can spread to the brain, the spine, the lungs, the breast, the bone, right, up to 7 areas, okay, bone cancer. So if I give you an example, the patient staging says T 1 N0 MX. Interpret. T1 N0 MX. What size is the tumor? Small tumor. And
It's not spreading.
there's no evidence of lymph node involvement. And yeah, we can't determine whether there is metastasis. Easy, right? Okay.
No.
So just look at the closest answer. Because definitely this will be a multiple choice question. We won't do grading. Okay, let's go to management. One more thing. As far as the tumor under TNM, now there are two types of tumors. A tumor can be primary or secondary. When they say primary tumor, this is the original tumor. So let's say I have M4. Okay, so let's say T4, N3, M4. What does that mean? A big tumor and okay, two lymph nodes and M4. There are 4 sites of metastasis. How many cancers does the patient have? A, 1, B, 2, C, 3, D, 4. 1. Because this is the same cancer that spread to 4 different body systems. Does that make sense? Okay, so meaning there's one primary tumor and the same tumor has spread to other body systems. So the patient has how many cancer? 1. Are we clear? Okay. Yeah. Go to management now. Very rare do you have multiple cancers. Usually you have one cancer and they spread. Right? You have to be very unlucky to have multiple tumors, right? To have multiple cancers. You're just really, yeah, nobody wants to be you. Okay, I mean, how could you have more than one cancer? So treatment options, there are many now, but we will only cover the 3 traditional treatments of cancer because the others are still out of reach of the average person. They're very expensive. Insurance companies, not all of them cover these treatments. So we will just cover the test and discuss the 3 traditional, which are radiation, chemotherapy, and surgery. Okay. The oldest method of managing cancer was surgery. Long ago, we haven't discovered radiation or made chemotherapy drugs yet. So the only way we manage cancer was there's a tumor, take it out. Okay, that's all we knew. So that's the oldest. And there's also different goals for cancer depending on what type of cancer do you have. So the treatment can be either cure, meaning the cancer must be curable, or control, meaning it's not curable, but we can control it. We can decrease the extent of the cancer and then make your life more comfortable. Okay, so that's control. And then of course there's palliation, which is just to keep you comfortable. Okay, this is for cases of really advanced cancer, and the objective is just to make the patient's last days, last months, or last year as comfortable as possible, as pain-free as possible. There can be overlapping though, because meaning for us to control and keep you comfortable, can that possibly include surgery, chemo, and radiation still? Yes, sometimes it's necessary because we have to be able to reduce the cancer size in order for you to be comfortable and pain-free. So let's look at the first one, surgery. There are many types of surgery. Surgery can be diagnostic. Number one example is a biopsy. We take either a needle biopsy or a surgical excision biopsy. Purpose is we take a sample of that tumor and then study it to make a diagnosis. So it can be excisional, meaning it's a minor surgery, or it can be needle biopsy, the least invasive of all biopsies. As already mentioned, it can be cure, meaning surgery as a primary treatment. We just take it out and then that's it. Examples are given here. So one example, which can be prophylactic as well, is the removal of colon polyps. Polyps are known to develop into cancer. So during a colonoscopy, if they see it, they remove it right away. Can be endoscopic, however the surgery is. But if it's primary treatment, that means this is for cure. Here are the other uses. Okay, what are the other types of surgery? Some of them are now bloodless or bloodless surgeries, meaning there's no scalpel involved. That is a form of laser or photodynamic or even radio frequency. Okay, so have you heard of the term cyberknife? Okay, so cyberknife is a type of precision radiotherapy, meaning radiation. Okay, they use radiation, precise amount of radiation to excise a tumor without opening the patient up. No scalpel involved, of course, no downtime. Patient goes home the same day. It may not be done in one sitting though. It may be a series of radiation therapies in order to finish to accomplish the goal. Here are a few examples. I'm not testing these. These are just nice to know. Prophylactic surgery, I gave you an example of the polyps. This is again to prevent the development of cancer in certain types of tissues. Here are a few examples besides the polyps. Angelina Jolie is the #1 most famous example. What did she have done? So what happened was she was positive for these, and then what did she do? Okay, take it out because she can afford it. Take it out, and then she didn't want to take the risk of developing it. Palliative, as already mentioned, so we cut something out to just make the patient comfortable, okay, to stop. Let's say examples would be, let's say you have a brain tumor and you're having seizures multiple times a day. Is that any way to live? No, so we'll take the tumor out or maybe shave it, cut a portion of it so you don't get increased ICP anymore, and then the seizures stop. That doesn't mean you're cured of cancer, okay, just to make you comfortable. Also for relieving pain, okay, it can also be done. Reconstructive, let's take Angelina Jolie. So we took out the pectoralis major, right? That's the muscle really that's involved. So we remove those muscles, and now it will leave a scar, or sometimes you lose one or both nipples, so that we can create a new nipple, right? So this is reconstructive to make your appearance acceptable to you again. For nursing management, there's really no difference from chapter 16, which is post-op care. So pre and post-op care, no different. It doesn't really matter whether it's for cancer or for heart surgery or for abdominal surgery. So we'll skip that. Any question on surgery? Let's proceed with radiation. For radiation therapy, there are two types of radiation. It's either external or internal radiation. External is also called radiation beam therapy, while internal is known as brachytherapy. Brachy meaning close or near. For brachy or internal radiation therapy, it can be sealed or unsealed. Let's take a look at each one. So the concept of radiation is to expose the cells. Of course, we cannot expose the cells only. It will have to include the normal cells. The only exception is in the thyroid. When we use radioactive iodine, no other cells are exposed, only the thyroid gland. However, in all other forms of radiation, that means if you give the patient radiation either externally or internally, the idea is the cells absorb radiation. Some of them die today. Some will continue dying later today, tomorrow, next week, and a few months later. That's the idea, to expose the cells to harmful radiation. They die. Again, it won't distinguish whether it's normal or malignant cells. They'll kill everything. So that's why the dosing has to be as accurate as possible. We have gone a long way though, from let's say 1960s radiation to 2024 radiation. Today we have more precise dosing and delivery of radiation now. So the last one I took care of was in the, I guess, 2006, maybe 2007. So the poor lady had breast cancer. No, it was lung cancer. And her radiation, of course, where are the lungs? In the chest, right? So at that time, at 2006, which was what, 18 years ago, so the technology wasn't that advanced. So it was like taking a shotgun, okay, to deliver radiation. So all her skin from here, from her neck down to her belly button, was all red and raw, like really major sunburn. So that's what the radiation did. Okay, so it radiated everything. So her skin was red, wet, weeping. Okay, so very tender. She just lay down in bed with no sheets. Okay, she cannot stand even putting a gown on or a thin sheet. No, she said, "Oh, leave me alone." She just wanted to be exposed. Okay, so all we could do was just draw the curtain to give her privacy. That's how painful the radiation burn was. So we call that radiation dermatitis. Okay, so now today we don't get that anymore. Okay, so because the radiation dosing is very precise, we have more innovative ways to deliver it so that we have the least amount of collateral damage to the overlying structures. So we've got the external and internal radiation. Let's go to dosing. So how do we calculate the dosing? There are three principles three elements to consider. So they are time, distance, and shielding. Again, time, distance, and shielding, TDS. Time, of course, the longer you are exposed to radiation, then the higher the dose, correct? And next is the distance. How far was the radiation source? Was it several feet away, or is it inside your body? Is it in the area around the tumor? And then finally, the amount of shielding. Can you shield the rest of your body or not? Of course, shielding will only work for external radiation. How do you shield if the radiation source is inside your body? We can't, correct? So the shielding part will only apply if the radiation therapy is external beam therapy or teleradiation. Okay, let's discuss external radiation and what the precautions are, because this is really the focus of our nursing care. What precautions do we take? And not only to us, but also the people around the patient. So external beam radiation. So this is very most common. So this is treatment at the treatment center. So let's say you go to Memorial Sloan, or let's say to, what's the famous one on Long Island? Somebody's name. Anyway, so we have several leaders for cancer radiation therapy. They use Gamma Knife. This is the most common now for external radiation. Very precise. So the whole idea is, where is the radiation source? Did the patient bring it home? No, it's in the treatment center. It's in their treatment room. So they turn on the machine, it delivers radiation, and where will the staff stay while the patient is being treated? Okay, so they're in a room, right? So in the room, they can observe the patient and they wear what? An apron, a lead apron. Okay, so they wear that while they're in the treatment room. So they sit behind a computer, patients laying down on the treatment table. For these also, remember, we do shielding, correct? And we need to be precise. So to deliver this, we will have to use position, forgot the term. We will have to use fiberglass moldings. So let's say the doctor decides, okay, the best approach, let's say that you have throat cancer. Okay, so the best approach here would be here. Okay, so we will create a mold, plastic mold of your face, because we need you to hold your face like this. Can the patient do that without any assistance? No, they'll grow tired, right? So they'll do this, they'll move down, we'll have collateral damage. No, we need you to keep your face exactly at this position. So to do that, we'll have to put a plaster, okay, a fiberglass usually. We'll create a fiberglass mold, slap it onto you in this position. Once that dries, you come in tomorrow, to put that on, you're forced to assume that position. Clear? Okay, so no, position fixing devices, that's it. So we'll use position fixing devices to make the treatment really accurate. So you'll be like this, like that. However, so that the delivery is precise, okay? So they can use Gamma Knife or any other type of radiation to deliver the treatment. Now, since the source is in the treatment center, does the patient bring it home? No. They were exposed to it. They go home, fine. Their family members are also fine, right? Because you only received the radiation while you were in there. All right. And then, of course, the rest of your body was covered with lead apron. Okay. So the rest of your body was fine. Any question on external? No. Okay. No problem. Internal will be more strict. So the term again is called brachytherapy. Brachy means near or close. Now, as I said, there are two types here. The brachytherapy can either be sealed. When we say sealed, it has a container, a pouch, a membrane, a sac, something that holds the radioactive material together, a container. Example would be for breast cancer. So how it works is, let's say they did surgery. So they remove a tumor, usually here, right? Here or here. So they made an incision, took out the tumor. Then there's a space there, right? Where the tumor was. You agree? Okay, so the space where the tumor was, they'll put something in there. They'll put radioactive seeds. So it usually has either an applicator, depending on the location. If it's here, the incision's here, they'll put a, have you seen, you've had edible arrangements? Yeah. So what did they use to position those flower shapes of the cantaloupe? And they had applicators, right? Plastic. Yeah. And then they're like plastic skewers. Okay, same thing. So they'll put the radioactive seeds on those sticks. At the tip of the stick, put them in a bunch, tie them with a rubber band, stick it up into the incision. All right, so that's one method. So these are sealed radiation because they had applicators and they had a, right, you tie them together. So therefore, does the radioactive material enter the bloodstream? Well, they're in the applicator. No, it doesn't enter because it has a a container. Okay, so some, let's say like a tea bag, for instance. Let's say they put it in a tea bag, shove it up into your uterus or inside your cervix. Okay, so that's another example. Okay, so they have a container, meaning they have a means to retrieve it. Does that make sense? Meaning if you put those sticks up there or that pouch there, they have a means of taking it out. Let's say if it's an intrauterine implant, there's a thread or a string by which they can pull it back out after the therapy is over. Does that make sense? So that is sealed radiation. The example of the unsealed is, we talked about it last semester under hyperthyroidism. Can also do it for thyroid cancer. So hyperthyroidism, thyroid cancer, same thing. You're destroying the thyroid. This time you swallowed the radiation, or it was injected to you. Either you swallowed it or it was injected. So therefore, if that's the form of radiation, can it enter the bloodstream now? Yes, it is in the bloodstream, right? You swallowed it, so it was absorbed in your bloodstream, in the duodenum, and then it circulated all over your body. Okay, so let's look at now the precautions, okay, between the two. Under here, under protecting caregivers. By caregivers, we don't only mean the nurses and the doctors, but also the family members, because these patients have to go home eventually. So if it is internal or brachytherapy unsealed, look at the distance and the time. Because it enters the bloodstream, so therefore, is anything wet coming out of this patient radioactive?
Yes.
Yes. Saliva,
Urine.
feces, anything wet, reproductive secretions, with the exception of tears and sweat. Tears and sweat are fine. You'll get something else from those body fluids, but not radiation. Okay, you'll get fungal infection or something, but not radiation. Yes, sir.
One time, so no tears, no sweat.
Yeah, just tears and sweat are safe. So you can drink those or lick those if you want. Okay, first up, safety precautions. Patient should be in a private room. Okay. Can we cohort them though? Say 2 patients with radiation? Yeah, if we have to, okay, we can cohort. Signs of course, radiation, okay, you have those radioactive signs, okay, big everywhere that people know what's in there.
Right.
Yes.
So saliva.
Yeah, everything else, anything wet, so saliva, mucus, mucus anywhere, mucus from the GI tract, mucus from the reproductive organs, or any orifice. All patient, caregivers that enter that room, by caregivers, I mean staff, right? So let's say you're a nurse, you go in there, you have to wear a badge, a dosimeter badge. Now, keep in mind, this badge offers no protection. What will the only thing that will protect you again? A lead apron. So you wear a lead apron when you enter this room, and you wear a dosimeter badge. What does this badge do? This will determine and measure how much radiation have you been exposed to, because you're taking care of this patient the whole day, correct? So that means, can you take care of more than one radioactive patient? Can you?
No.
Should you?
No.
No, because it will add up, right? Because you have only how much are we limited to? 30 minutes per day. That's it. That's your limit. So how do you account? You work 12 hours. How are you gonna budget this 30 minutes? Are you gonna ask somebody else, hey, can you go in there too? I'm close to my quota. Can you do that? Well, you can. However, should you? No, this is your patient. Do not expose unnecessarily your other staff members. Okay, so be efficient. So let's say you go in there, you have to give meds, start an IV, take vital signs. Are you gonna send your vital signs? That's not my job. Hannah, you go in there. That's your job. Do I do that? No, don't do that, because you can do that while you're in there, right? You're going in there anyway. So only enter the room and be with the patient only as long as necessary. Do I have to be at the patient's within 6 feet to talk to them? No, I can just even be on the phone, correct? So only go to the patient within 6 feet. Let's say you're inserting a Foley, you're starting an IV, you're giving a medication. Okay, so let's say it's a PO medication. All you do is, what would be the best thing to do? Yeah, so just go in there a few seconds. Here's your pill, and then back up. Okay, back up. Stay longer than 6 feet. So stay 6 feet or longer away. Okay, so you're safe. Okay, so talk to the patient. What else do you need? Oh, you got doo-doo. Okay, so prepare everything first. The soap, the the gown, everything you need, so that you go in there and you're already ready. Okay, because you want to only, what's your limit? 30 minutes. Okay, you have to spread that out over the entire shift. And only as necessary. So if it's not necessary, stay 6 feet away at all times. Okay. So of course, while you're close to the patient during this 30 minutes, you have to wear a lead apron. Guess where I'm wearing my apron?
Of course you can.
Right here. This is the most important. Okay. Just right here for me. I don't care about the other body parts. Yep. Any question? Have at it. What's the most important for you? Usually it's neck down, right? Because there's really no lead apron for the head. You don't have one. Or you can improvise, you can wrap it. Yeah, you can make your own. So this is for internal, okay? And then of course, common sense, anything wet, anything soiled, or if there's a soiled sheets with urine and feces or saliva in it, what do we do? Do we mix them with everything else? No, they have to be washed separately. Okay. Usually what we do is, if it's internal radiation like this, we leave it in the room. We pack them in a bag, leave them in the room, and then we'll take them all out at once. All right. That way, they're segregated, that this is radioactive material, washed separately. And like I said, they eventually return home. So when they're at home, do the same. Of course, we don't have lead aprons, right? For the home. So these patients, can they mix with the rest of the family? No, they should be in their own room. Again, 6 feet. It's okay. They can come home, but should the caregivers be, children be within 6 feet? No, they can just, hi, okay, or do a selfie stick. We can do a selfie. Hey, 6 feet. A selfie stick can be 6 feet, right? With your hands, yeah, something like that. Or you can even use a selfie stick when you hand something to the patient. Okay, Fate comes in there. Hey, can you stick a Foley in with a selfie stick? Oh, you have to be really talented to do that, right? And you need a sterile selfie stick. If it's sealed, we'll just simply double the time and then shorten the distance. If it's sealed, so let's say I have one of those edible arrangement things, applicator, meaning it's sealed, right? So it doesn't enter body fluids. So body fluids are okay. However, because the patient didn't swallow it. However, because the radioactive material is in the patient's body, you still observe 3 feet. You stay 3 feet away, but because now it's sealed, you can go 1 hour, maximum 1 hour. And that's the only difference. Unsealed, 30 minutes, 6 feet. Sealed, how much? 1 hour and 3 feet. But these are, of course, only guidelines, okay? Of course, would I really go 3 feet? Nah, I'll go 6 feet. But for testing purposes, 3 feet is okay and up to 60 minutes if it's sealed. Any question on radiation? Okay. For caring, I will get to the skincare later. Let's take a break and then we'll start with chemotherapy.